one more thing. Make sure first you're sharing your screen.
Okay, can you see my screen?
Yes. And whatever people online are saying, try to repeat it so it's clear to the people later on listening to the sessions. What was the discussion? Because they cannot hear the ones online.
Yeah, sure, inshallah. Okay, so we'll start. Can you see my screen now? Full screen?
Yes.
Okay. Assalamu alaikum wa rahmatullah. Now we'll start the fourth session of the CMQ study group, the patient safety. Just we'll make, as usual, we'll make like a refreshing sessions, questions for the previous chapter. The previous was about the quality measurement. So the first question, the quality measures allow for results to be available by distribution of a report when it's most needed by consumers. This described on the below quality measurement characteristics. So the below, there are characteristics of the measurements. It talks about quality measures allow to the result to be available by distribution of a report when it's mostly needed by consumer. Is it timeless? Availability? Sorry, I repeated timeless. Reliability and stability. What do you think? Timeliness. Anyone else tell me another? Sorry, but there was a mistake. Should be a reliability, so it's fine. So any other suggestions? Availability. Okay. Sabita, why you choose timeliness?
It is the most desirable characteristic for a quality measurement. And even stability is also.
Yes.
Yeah.
Okay, so let us see the answer. It is timeliness. Because here we are talking about this measure talks about the availability of the distribution of the report for the consumers. It means that whenever the consumers or for the the healthcare provider need the data, it will be available. So it talks about the time. Yeah, it is kind of confusing between the availability and the timeless, but however, the availability, when the data is available, when we can be able to extract the report. However, when it's on the time, when we need the time to be available, so it goes about timeless. Okay. Here, Belden and Nelson works has creating the foundation for BDSA, cloud computing, root cause analysis tool, or scorecard and benchmark.
Scorecard and benchmark.
Okay. What else?
Scorecard and benchmark.
Scorecard and benchmark. Oh, sorry. So it is scorecard and benchmark, correct. To assess the proportion of patients admitted with this diagnosis who receive beta blockers within 24 hours after hospital arrival, talks about heart failure. This measure considered as a knowledge, structural, process, or none of the above.
Process.
Why we use process? Why it's not a knowledge or structural?
Measuring the process of heart failure.
Yeah.
Given through the beta blockers.
So it's correct, it's process. One of the ways to measure the surveillance using count, median or mean, ratio or percentage. Surveillance, or if you want to measure the number of adverse events. So how can we measure? Through median and mean, or through ratios, or percentage wise, or by count?
Median and mean.
Median and mean, okay. What else? If we want to measure adverse events.
Count, no?
count. Let me see the answer. Count. Because if you want to know how many, for example, adverse events, how many medication errors, how many, for example, number of doses, those are surveillance concept. That's why we need to have a count. So,
Also, you mentioned
sorry?
Count is the smallest, is used for very small numbers.
Okay.
So remember we said something like sentinel events, the medication errors will not be using counts, we'll mainly be using other means or medians or something because the number is high. But anything that has smaller numbers, and that's why they say it's used in surveillance and it does not have much of value when it comes to comparison with other methods. You cannot compare. If you compare a count of 3 to count of 6, it doesn't make any
value of
any statistics to the person who is collecting that. It's the most basic, and it's only used, as Rahab said, in surveillance and when it's really very small number of events or a very small number of things that needs to be counted. Thank you, Rahab.
Thank you, Zahra. So now we have the patient safety with chapter 4. We'll be able to discuss during this study about the history, about the patient safety, and also as well the systems approach to prevent the errors, as well the types of the errors and the organizational culture, and the process and to identify and to analyze the errors, as well the teamwork and the crew source. So in the beginning, the first thing as we know all, during the graduation of the medical students, usually they will recite the Hippocratic Oath. And the Hippocrates, the Hippocrates, one of the founder of the medicine in the ancient history. So one of the wording in the Hippocratic Oath, I will not do harm or injustice for the patients. So first, do not harm. So this is the main concept of the safety. If we will talk about safety, is to not do harm for the patients or for someone. So this is the main concept of a safety. Second, after the Hippocratic Oath was do not harm, then we have a Simulus, the founder of the infection control and the founder of hand washing in the 19th century, because he developed or he proposed that hand washing before entering the patient to prevent the infection, followed by the Kunman, which is the end result theory, the surgical or the surgeon who was following the patient post-surgery through the surgical cards to identify the errors post-surgery. Followed by Schimmel. Schimmel in the 19th century, he discussed, especially in 1964, he discussed about the errors, or he's done studies about the adverse events in a group of hospitalized patients, and he found that 20% of the admitted patients had ADRs and 6.6% were fatal incident. In the new century, in the 1994, Lucien Lieb he also studied the psychology of the medication errors and the human performance. As we all know, the Institute of Medicine discussed, the Institute of Medicine have the report to err is human and discuss about the medication errors and the strategy to prevent the occurrence of the medication errors. So, the error as a system issue. So, what do you define? What's the unsafe act? It's an error or violation committed in the presence of potential harm. So, if we discuss or if we describe the error, it comes like a triangle in invert position. So, to have an error or to have an arm, we'll have the blunt end and sharp end. So if you consider the harm is in the sharp end, so there will be kind of process. The process then when to do the act and the act itself. The act is the error, and the person or the direct error when it occurs, it will be in the sharp end, and the processes causing the harm, it will be the blunt end. So if this is the harm, which comes in the end of the triangle, was caused by the sharp end. As we know, the sharp end comes the direct cause of the error, which is usually caused by a person or individuals or group of people. That's why it have direct impact. That's why it's called a person approach. However, if we dig more on the causes of the error, we'll find that like latent failures mean the procedures, the processes, the education, the training, those are considered as the latent failure, which is the cause the harm of the or cause the, or creating the environment or the atmosphere to cause the harm, which is the latent failure, which is the system approach. So we'll have a harm, then the harm, there will be the active failures, mean, for example, missing the doses, for example, or duplication of the doses, or giving for the wrong patient, which is caused by a person or individuals or group of people. That's why it will be the direct effect, which is the active failure. However, if we dig more on the cause of the failure, we'll find the system approach, which is due to lack, for example, of education, lack of resources, system failure, for example, which is caused at the blunt end. So if we define the active failure, it's the wrong plan is selected or when the right plan is poorly executed due to cognitive activity involved. However, the latent failure, which is in the blunt end, or the procedure that caused the error, usually because of poor supervision, training and education, poor design of for task, inadequate staffing levels, impractical and unworkable processes, and inadequate tools, and poorly designed or implemented automated system. So, what do you see from this picture? What do you have any kind of thoughts? Why I put this picture?
The cheese model.
Cheese model. So that person is the James Reason, who developed the cheese model. So why? What do you feel? And what's your thought? What is the cheese model?
How the harm is reaching the patient through the various hazards and through the barriers.
That's
with
right.
The different layers of defenses we have, but with the barriers, still it reaches the patient, the harm and the scattered whole.
That's right. That's right. This is the mental cheese, although I don't like the mental cheese. Anyway, so the mental cheese.
Sorry to interrupt you. Can I ask a question?
Yeah.
So, when we're talking about this Swiss cheese model, if we wanted to link it with the previous slide, is it addressing the latent or the active errors?
Shall I answer for the group?
Latent failures.
Latent failures. So it does address mainly system issues and latent failures that result in the error. Thank you. Just wanted to link it back to the previous slide. Thank you very much.
Thank you. Thank you. So, as Zahra said, and also Sabita said, so this is the cheese model, which is developed by James Reason in his book Human Errors. So those are the barriers which is usual in our system. The holes considered are the latent failure. When there is an error, it means when all of those holes are aligned together, causing the harm. So those are the barriers, those are the latent failure. When those holes are structured in a way causing in a one line, then the harm will occur. So as she said, Zahra, this is the failure, this is the error, This is the active failure, which is the direct cause for the error. However, in the back end, we have latent failures causing this. Sorry. So, what is the other name of Swiss cheese model? Do you know?
System approach.
No, the system approach, this is the latent. The system approach, this is the other name of the latent failure. So, cumulative act effect. Also, this is the other name of Swiss cheese model. So, error classification. So, James Reason in his...
You can go back to the Swiss cheese model and maybe give an example of, maybe ask someone to give you an example of how errors can align in order to cause harm, and they could, still go through all of the barriers and all of the safety checks that we usually have in place.
Medication errors.
Excellent. How so?
Because the order will start from the physician. However, he might put a wrong dose and it will be checked by the pharmacist and prepared. This is the first guard. Then the pharmacist, he will pass it through the system to the next level. Maybe another person he's checking and he will miss that there is a wrong dose. It was there. It will go to the nurse, then it will be also another third guard. So also it will fail sometimes, or it might be catched by the nurse or by the second, maybe who is auditing or who is reviewing the dose. However, it might also be missed and given, reach to the patient and the harm caused. So all of these barriers or guards, it was just skipped, or maybe the holes at certain, maybe the people, they are overworking, or they have certain circumstances, understaffing. It's system issues it will cause, and the medication will reach the patient.
Excellent example, Hania. Thank you.
Zahra, quick question. Also, can the Swiss cheese model almost the same, like if you will think about the fishbone when we identify?
The fishbone is only identifying cause and effect.
Yes, yeah.
Yep. The Swiss cheese is telling you how sometimes, consider these cheeses is your like the systems you put in place to prevent error from happening. So you have the prescribing order, you already have the electronic medical system alerting you, then you have the pharmacist checking for correctness, and then you have the nurses checking the medication, actually two pharmacists checking for correctness before it's dispensed, and then the nurse reviewing it, and the one receiving the medicine reviewing it, and then the one administering the medicine checking the 7 rights and all. If there is that hole in each one of those processes, then that error finds a direct way of going through all of those cheeses or protections that you put in place and harming your patient eventually. So the idea is that even if you have safety mechanisms, sometimes because of what Hania was mentioning, like either all the system issues we talked about, either overworked employees, not enough people to do the double checks, just differences in the in the person checking and the person who's supposed to double check will say, okay, I trust the first person, not mushkila, let me just sign the document. So all of that is going to be the one causing or reaching for this to allowing for this to reach to the patient. So it's not a cause and effect relationship, it's more like the error is able to pass freely through all of those holes in the cheese.
Okay, thank you, Zahra. So
can I just give a comment? If you go back to the cheese, that those holes usually it's not matching, like in this red line. Usually the cheese, the holes, it won't be on the same direction. But however, the error will find a way that to connect his way. I mean, how he can find his way through those holes. This is the idea, the initial idea. How this error, it can happen even those holes, it's not on the same line within the cheese. You can imagine it. Sometimes because this one, they are giving this straight hole, it's like sometimes confusing how it could happen. But actually the holes in the real cheese, it's not matching. The same hole, it won't be in Emmental cheese, it won't be on the same line with this straight red line.
That's true. So it might be on the top of one slice, at the bottom of the other, at the middle of the other. The only thing is that the cheeses, they will align in a way that allows
circumstance, because of external circumstance, cause that to be aligned.
Yeah.
Okay. So Human Error book by James Reasons, also he discussed about how to classify the errors based on the cognitive activities. He classified the errors to skill-based activity or rule-based activity or knowledge-based activity. So the skill-based usually, which is the autopilot, which is the usually we are doing on a daily basis, that doesn't need the full concentration, which is always that's why it's your habitual act or habitual task that you are doing. Can you give me an example of skill-based activity?
Like when you are driving your car to the work.
Yes. What else?
It's actually like when you are sometimes maybe checking your daily tasks, or
that's right, yeah.
Or you're doing your this like for the nurses, for example, they are always maybe making the bed of the patient.
Mm-hmm.
Sometimes it's without thinking.
That's right.
You are folding the bed sheet. You will just do it. You will just put your hand under the mattress, and this is skill based.
That's right. So
vital signs also, no? Taking vital signs and administering medication.
Yes, that's right. Or dispensing, yeah. So usually the skill base always automatic, fast, doesn't need full concentration. However, what type of error comes from the skill based? For example, give me an error.
Yeah, sometimes slips. Sometimes.
That's right. Yeah. What is slips?
Like maybe, like for example, you are giving a medication, IV medication.
Mm-hmm.
It maybe rub the tip of the IV line. Then you will miss to rub that one, and maybe you crossed a contamination. However, it's just like a slip of not rubbing that rubber, the tip of the rubber. This is what's coming in my mind. Okay.
Also, from one of the examples of skill based, for example, duplication or missing doses.
Yes.
Yeah. So 1 minute. Let me see. Slips, lapses, omission, duplication, and confusion. The rule based. What do you feel about the rule based? What comes on your mind when I say rule based activity? Policies. Okay, what do you mean by the policies?
There are so many plans or policies or workflows,
Yes.
and we are trying to get the shortcut of it.
Okay, because one of the examples that mentioned in the book, for example, if, for example, there is a management for certain medications for certain disease. However, by default, you'll use this, for example, for all patients, for example, management of hospital-acquired, or not hospital, community-acquired pneumonia. And you implement this protocol for all patients who are in community-acquired pneumonia. However, you may miss it, or you may use it wrongly for the wrong category of patients. So based on the rule, this is a patient, he's a patient who is having kind of pneumonia. So according to the management, you will have certain kind of treatment plan for this patient. However, this patient have other comorbidities or have other conditions that prohibit for this kind of treatment. This is kind of rule-based activity. Then we have a knowledge-based activity. What do you feel about the knowledge-based activity?
It's based on in your understanding and awareness.
Mm-hmm.
Your knowledge, how you can treat a case,
Mm-hmm.
based on your knowledge and what we will call that, like, and how you can implement it, like the surgeons maybe, how they can perform a surgery.
So why do you feel like, for example, which is right example, pay a surgeon to perform a surgery, why do you feel that he may have an error? Or for example, not a surgery, for example, a patient came to a physician and he misdiagnosed something about the patient. Why do you feel that's an error, or what caused this error?
Complexity of the case, sometimes multiple comorbidities.
So
Yes.
it is new for the physician, am I right? So this case is a new, or he doesn't know about the diagnosis, am I right?
Yeah, like sometimes if they will do laparotomy, for example,
Okay.
the surgeons, they might expect maybe they are just doing it to explore X something, then they will discover another thing that they were not even thinking about, even though that they have a knowledge base.
Yes, of course, mostly about this kind of activity or this kind of error usually is linked with the consciousness and linked with the complexity, as you said, and being a novel or being something new for the physician or something new for the healthcare provider to perform. If it's a new task or complex task, he will take time to perform, take time to concentrate on how to do it and what is the best way to do it. So it's some kind of complexity because something new for the physician or for the nurse or the pharmacist to perform. This can lead kind of errors, which is the knowledge-based activity. So whatever new and whatever need more concentration due to the complexity of the case, then it's a knowledge-based activity. For example, incorrect diagnosis for challenging cases. What is the difference as before slips, lapses, and mistakes? And to be honest with you, I'm usually using mistakes. I thought that the mistakes and slips and lapses are the same, but I found out no, they are different. So what is your idea about the difference between lapses, slips, and mistake? What is the major differentiation between the three of them?
Slips, it's just unintentional, I think.
Okay,
It's like-
tamam, excellent.
Yeah, something like the people, they will do it unintentionally.
Correct.
Slaps, like in the policy, you will have a procedure, you will have a diet instructions. However, the people, they intend to have shortcuts, let's say,
Mm-hmm.
like for example, for controlled medication. It's the most I can describe. Like controlled medication, I should have like Sabita to check on my dose. or to witness that I discarded the remaining maybe bethadine or whatever.
Excellent.
But sometimes, okay, Sabita, she's busy. I will say like, I discard maybe 1 ml and I give another 1 ml. Then we will sign both together. This is a slap. It's just like intentionally, both of us, we are aware that we are doing something wrong. However, because we are friends, so you just, خلاص يلا, we will do it. Mistake that you are taking the chance and you just doing it sometimes deliberately, because maybe the people, they will intend to take the shortcut. They are aware, but sometimes they are not aware about the policy or what is the update of the policies or what is the updated procedures, or they did not have an idea about a knowledge-based procedure. Then the mistake will happen.
Okay. So part of it is correct. So very easy classification. Slips and lapses, both of them are structural based rule. However, the mistakes considered as the knowledge. Here, can you see the screen? Maybe it's small. Here they're saying the skill-based errors, usually it's slips of action or lapses of memory. Usually, where there are slips, not doing what you are meant to do. When you want, if, for example, as you say, for example, the control medication. Supposedly we need to verify the control medication or double check the counting. So suppose this is your you have to do it. If you didn't do it, so it's a slips. For example, however, the lapses, if you forget to do something, which is usually related to the memory, but however, the slips, for example, you need to double check the medication before administration, and you didn't do it, then so it's a slips. If you forget to do it, it's lapses. However, the mistakes links only for the knowledge, for the knowledge-based activities, like a rule and a knowledge. For example, when you decision-making failure, this means 2 types. This is the usual related to the mistakes. When we use the wording mistake, we always link it when we have a lack of knowledge or lack of, as you mentioned, that for the narcotic, knowing the narcotic guidelines and how to deal with the narcotic guidelines, so it's a mistake. However, when you are doing the daily practices for a while, for example, dosing, administration, dispensing, if you missed medication, you use other medication instead of other, if you, for example, dispense a medication, for example, atenolol, however, the prescribing was for labetalol, this is a slips. However, if you forget to double check, so it's a lapses. This is the main difference. So this is very nice. I found this kind of picture. The skill-based performance or skill-based errors, usually it's an autopilot mode, which is your habitual performance. However, the rule-based, it is usually they are saying if then response mode. And for example, if there is a patient with VAP, this is the treatment. So this is the rule-based mode. However, the knowledge-based performance is figuring out mode, which is I like this one because links how we can know the knowledge and the rule and the skill. So the strategies to fight the skill-based activity errors, usually when we have skill-based activity, usually we have kind of forcing functions, for example, alert or hard stop, workflow redesigning, using the checklist, using the automation, pharmacy automation. Sometimes you need to have to stop to double check or to have a conscious pause when you are dispensing a medication. You need to stop and do rechecking by yourself. So this is one of the strategies, or there are strategies to perform to overcome the skill-based activity error. What is the best strategy for the confirmation bias? For example, the confirmation bias usually, if you have a diagnosis and you are habitual know this diagnosis, so by default, for example, sometimes for me as a pharmacist, if I am get used to dispense something, for example, lookalike medications or anything, this is cause of by default. Oh, this is the medication. I never double check it. I used dispense this medication. So what is the best strategy to overcome the confirmation bias?
Double check.
Yeah, because I said so usually to overcome the confirmation bias is to have independent double checking by yourself or by other colleague to overcome this double checking. To overcome the confirmation bias. Okay. So human factors, usually the errors caused by humans. So there is kind of human factors causing this error. One of the errors or causes causing by human factor is fatigue. In this century, there's one patient called Libby Zion. She was 18 years old and she was being admitted in the hospital because of fever and agitation. However, she passed away while she was admitted in the hospital. And when they reviewed the case, they found that when they done root cause analysis and why she was being passed away in the hospital, they found that because of lack of supervision of the physician and the nurses, and when they checked why there was lack of supervision, and they found that the prolonged duty hours of the healthcare provider about her case. That's why, because of her case, they structure guidelines and regarding the duty hours and the maximum duty hours per week. So the factors that cause human errors is fatigue, prolonged working hours, non-standard schedules, interaction or responsibility, work-related stress or physical fatigue, inadequate having rest or sleep. Mostly, majority of the errors happens between, as per the studies, some of the studies, usually the errors happens between the 3 a.m. in the morning and 3 p.m. because of the workload. And there was very nice study that's done by Dawson. They said that if someone doesn't sleep for 24 hours, as if he is taking alcohol, and almost 0.1% showing in her blood. They recommended that the nursing shifts, they should not work more than 12 hours, 40 hours per week to avoid medication errors and causing fatigue for the staff. So strategies to avoid the fatigue or avoid strategies for errors caused by fatigue: alerting schedule, limiting the number of duty hours, strategic use of stimulant, do not overuse of caffeine, having nap periods on call, avoid scheduling double shifts, using bright light, and also simplify the processes during the work, and having healthy sleep habits. The second cause of error done by human factor is the alarms. Usually the safety alarms that's showing in our systems. Sometimes it is beneficial sometimes beneficial to have alarms because it will identify the errors or potential errors that comes in the system. However, as we know, using a lot of alarm can cause have a false positive alarm. So by default, the staff can ignore those alarms. Then once they are ignoring or deactivating the alarms, so there will be a potential having errors or medication errors or harm to the patients.
Yes, override.
Yes, the override was causing because of the override. So another definitions for the errors, there's medication errors, adverse reaction, preventable, sentinel, and near miss. The medication errors is the error caused during the medication process. However, the ADR, this is the unexpected event or dangerous reaction caused by the medication. The preventable adverse reaction is the adverse reaction caused by the medication error. The sentinel, when there is an error or adverse event causing death or permanent injury. The near miss, when the error could cause harm but didn't reach the patients. So if we classify the medication errors during the medication loop or the medication processes, there will be a prescribing, transcribing, dispensing, administration, monitoring, and ambulatory. The prescribing usually due to poor documentation. Can you give me an example of a prescribing error? Sorry?
Wrong medication prescribed for a patient.
That's right.
Wrong dose.
Wrong dose.
Wrong patient.
Or as well, wrong patient, yes. However, the transcribing, sorry, Sabi?
Illegible handwriting. Like, remember how the doctor's handwriting is not clear when they're writing a medicine. Is this considered a prescribing error, or it would be under dispensing or maybe administration?
Prescribe.
Maybe
Transcribing.
Okay.
Zahra?
No, I'm just asking. I didn't know. I was gonna give it as an example, and then I realized it might be under transcribing or
Yes.
actually under administration. So I became confused by my own answer.
Sorry, Sarah, you remind me of those jokes when they were saying like a doctor, he wrote a letter for his fiance, then they took it for the pharmacist to transcribe what he wrote.
That's good.
So the transcribing, can you give me an example of a transcribing when we can transcribing cause an error?
Illegible, as we said, handwriting, and maybe before when they used to write unit, used to show as 0 in the beginning.
That's right.
We can say the new system, like if there is the accent of the prescriber, the physician, because you see on the translating sometimes if the accent of the prescriber not clear, maybe
Correct.
It might cause.
Yeah. During the verbal orders, for example, during the verbal orders. And also during the downtime, and usually for during the downtime, I'm not sure it's the right. I think during the downtime when we are using the downtime forms, then when the system retrieve back, then that it should be transcribed back in the system. So this is also it's a phase can cause error when if we transcribe wrongly from the downtime reports or downtime document into the system. What do you think, Zahra, in this example?
I think it's very relevant to what you're saying.
So, then we'll have dispensing. Give me an example of a dispensing errors can cause.
Dispensing wrong dose,
Wrong dose.
medicine,
Yes, that's right.
Look alike some of the like medication, sometimes when they're dispensing it,
Yes.
they give a wrong medicine because it looks or it sounds like another medicine.
Yeah. And I forgot to mention, usually the prescribing, who will be the responsible? I forgot to mention it here. The prescribing, it is who will be the responsible personnel for causing the prescribing?
Physician.
Physicians, yes, that's right. However, the transcribing,
It can be the physician and it can be also the receiver, the pharmacist.
yes, that's right. The dispensing definitely solo, it is an pharmacist.
Pharmacist.
Yeah. Administration. Give me an example of administration.
Wrong patient.
Wrong patient, yeah.
Wrong dose.
Yes, that's right. Wrong route of administration.
Wrong route.
Yeah.
Wrong lab.
Yeah. And it should be performed by whom?
Nurse.
By a nurse or sometimes physicians, صح?
physician.
Yeah, it can be also by physicians, yeah. Then we will have the monitoring errors. Give me an example of a monitoring errors.
Like on pumps, maybe medication like continuous infusion,
Mm-hmm.
maybe wrong calibration,
Okay. What else?
monitoring. It can be also for laboratory results.
That's right.
The monitor-
Yes, that's right. Okay. The ambulatory. Sorry. The ambulatory. Can you give me an example in the ambulatory setting errors?
Educating the patient
Yeah.
by mistake, instead of PRN,
Mm.
they take regularly.
That's right. This is usually, as you mentioned, the ambulatory links always by the education. Because usually the ambulatory, in a majority as per, they usually for elderly or polypharmacy cases. That's usually, so that's why it links only about the education, or even it links if there is kind of errors in transcribing the medications. So this is usually the ambulatory errors. So, okay, yeah.
Sorry, I was gonna say about
Yeah.
ambulatory errors. That's also the errors of, multiple physicians are seeing the same patients, especially those who have complex diagnoses. And sometimes they either order similar medications or contradicting medications without sometimes going back to their records. I had a situation where one of my friends was complaining that her father takes about 16 tablets in the morning, and when they reviewed, they found that some of those medications are actually the same. For example, vitamin that has, that's being dispensed from nephrologist, one from cardiologist. Some medications that are affecting the kidney given by the cardiologist, while the nephrologist has started some medications that is reducing the effect. So it was really like when it says here polypharmacy in elderly, it is really a very big issue for some of the patients.
Thank you, Zahra. So, how do you measure the medication errors or ADRs? through what? They're saying incident reporting. Through the incident reporting, we can collect data about the medication errors and adherence. Also through direct observation. As well also the chart reviews. When we want to measure the ADRs, we can review the records of the patient, and we can use a trigger tool for analysis of the ADRs. What is the highest medication errors incident occurrence in the medication loop? And is it prescribing? Is it dispensing? Is it administration? Is it monitoring or ambulatory? What do you think? What do you expect that? What is the highest incident occurrence or frequency? At which level? Prescribing. What else?
And administration.
And administration. Correct. So majority of the errors comes in the prescribing. Let me just put it here as well. And administration, which is mostly done by the physician and the nurses. So majority it comes in the prescribing and administration. So at prescribing, 15 to 1,400 errors per 1,000 admission. Usually the prescribing number of prescribing, it comes at 15 to 1,400 errors per 1,000 admission, which will equal to 0.5 to 50 errors per 1,000 orders. The administration usually it comes at occurrence, the frequency is almost from 3 to 11%. And the nursing home have the highest, the nursing home have highest administration errors more than the hospital inpatient rates by twice. The ADRs usually is 1 to 2 events per 100 hospital admission, or 3 to 6 events per 1,000 patient days. Preventable ADRs usually 25 to 50% of all ADRs in inpatient setting. So there's some high risk areas that cause errors, usually for medication errors. Usually in hypoglycemia, because sometimes if there's an overdose of medication, as you know, the insulin, it is a high risk medication. So the possibility of having medication errors, it is high, so can cause hypoglycemia. As well also the opioids, having wrong dose of any kind of opioid medications can cause respiratory failure. As well also the chemotherapy medication, which, as you know, it's as nature, it's a toxic medication. So having wrong doses of chemotherapy medication can cause death. What is the preventable measure to prevent errors in the chemotherapy? What do you think? What is, if you have a chemotherapy medication, what is the strategic process to avoid medication errors in the chemotherapy?
Double checking.
Double checking, yes.
Reconciliation.
Reconciliation, okay.
A patient's history prior and pre-medications.
Mm-hmm. Which is the normal, those are the normal medication review. But there's something specifically for the chemotherapy. Yeah, I agree with the medication reconciliation, double checking, which is the normal for any kind of medication dispensing, but and administration. But there is other strategic link to the chemotherapy. What do you think? Interaction also is even in the normal process of medication process loop.
No, I mean standardization of the procedures.
Excellent.
Maybe
yes, that's right.
The kits, what we are calling that. There's something. They usually the care set they are calling it, huh?
which means the protocol standard of the protocol of the chemotherapy. Am I right?
All of that chemotherapy.
Yes, that's right.
Trying to remember.
Yeah. What else? So use
Training and competence.
yes, that's right. Use chemotherapy trained staff and competency, because as you know, the chemotherapy medication, due to the toxicity by nature of this medication, it needs certain training and certain competency. So the staff who will handle, regardless of this physician or nursing or the pharmacist, they should undergo specific training to handle the chemotherapy medications. Also, as Hania said, that to use standard protocol related to the chemotherapy, because as you know, the chemotherapy medication have specific kind of dosing for the patients, and it is tailored based on the patient. So to avoid such errors, you need to have a standard dosing protocol. So preventable measures or strategies. In general, to avoid any errors, we'll have system intervention. Can you give me an example of system intervention rather than the one in the mentioned here, rather than the labeling, the indication, the analysis, and standing? What do you think as a system intervention, how can we use to prevent errors? Give me an example from your experience.
Independent double checking for like medication.
Mm-hmm. However, it is not linked to the system level.
Because we will be signing in the Salam Tak.
Okay, tamam.
Order sets.
Order sets, okay.
Pop-up alert.
Sorry?
Pop-up alerts in case if it is having an interaction with some drug.
Okay. What else? For example, formulary, having standard formulary medications. So, medication reconciliation. Can you tell me how can medication reconciliation prevent errors? And what?
The example that I used earlier, many medications, it might interact with each other.
Mm-hmm.
Some, it might cause hypoglycemia. Other medication, it might cause maybe hypertensive records. So the reconciliation really helps on improving the way how the medication is prescribed.
And what is the medication reconciliation? If we want to define.
The medication reconciliation is reviewing what the patient have and what is the new medication will be on the system.
Mm-hmm.
If he is admitted.
Or taking patient history.
During taking patient history, yes.
Okay. How about the computer CPOE? How come the CPOE can reduce or prevent errors?
The typo.
Okay. Tamam. As Zahra said before, the eligibility is, for example, rather than to have handwriting, you will have the typo. What else?
I can review the previous medications.
Mm-hmm.
And I think Tara said good example that if the patient was seen by multiple physicians, it will be reflecting and part of
That's right.
system we can capture those medication and prescribe accordingly.
Excellent. What else?
Medications. The system will catch that this is high alert or high dose.
Mm-hmm. And also it supports you with informations. If, for example, this medication dosing range, for example. Pharmacy automation. For pharmacy automation, I'm not sure if Mariam with us or no.
Yes.
Mariam, can you just tell us how pharmacy automation can reduce errors?
Yeah, we can depend on the, let's say, robot or machine to reduce like preparation errors. As a human factor can affect the preparation. So when we depend on a robot or machine, this can help.
That's right. Double checking process. Thank you, Mariam. Double checking process. Can you give me an example how double checking process can reduce errors?
High attack medications, specifically independent double checking, can prevent errors.
Okay. From your daily work, can you give me an example? For example, as you mentioned before, Hania, narcotic double checking. What else? And also
the heparin dose.
heparin.
Chemo medications.
Forcing functions. Why do we feel that the forcing function can prevent errors? What is your thoughts? How can forcing function reduce errors?
It will avoid variations in practice.
Mm-hmm.
So there will be a force function to stop the variations.
Mm. That's right.
The dosage variation also.
Dosing variation, yes. Patient empowerment. How can patient empowerment reduce the errors?
Their knowledge and education.
Yes, that's right. Yeah, through asking the patient, and patient can share his feedback. This one can reduce errors. For example, when you chit chat with the patient, that how do you take your medications? How do you feel? Those are kind of conversation or patient engagement in his therapy can reduce errors. You can capture through discussion with the patient any medication events occurred during his therapy treatment. So, what are the risk areas which are impacting the patient safety? They discussed 2 or 3 areas. Invasive procedures, which is the high risk area having patient safety. Why do you feel that invasive procedures can impact the patient safety and consider one of the risk areas?
It's high risk. High volume.
It can cause irreversible harm.
And will not deliver the intended treatment, sometimes leading to misdiagnosis or delayed diagnosis or delayed treatment.
Okay, so during the preparation of procedure, how do you make sure that there is no error can caused by during the infancy? What is the pre-protocols or pre-functions? Being from your experience, Sabita, what are the procedures that you usually the physician or the nursing is doing in the theater before the procedures?
Time out and sign.
Time out. So what is a time out?
It's a pause just prior to the procedure. In order to verify, we make sure that the correct patient, correct procedure, correct site is being done. with all the equipments available.
Mm-hmm.
Especially the site and even including the team, the surgeon,
Okay.
and the team who is performing the procedure.
Privileging, checking the privilege of the patient.
Okay. So, to prevent any invasive procedure, usually we are, as you said, Sabita and Hania, that we utilize the timeout checklist, which is the checklist done to perform before the procedure to make sure that all the elements, to make sure that there is no error, can occur during the procedure, like wrong site, wrong procedure, wrong person. Those are the errors that can cause during the procedure, following what they are called the universal protocol, performed by the Joint Commission. So the second risk area, the perioperative complications, which is after the procedure. Deep venous thrombosis. Anyone just give me her thoughts about the DVT?
Risk of clotting during the procedure, and patient may have pulmonary embolism, which is life-threatening.
Okay.
Sometimes loss of the limb by the DVT also. That is another limb threatening.
So what you are usually doing?
We will be having a prophylactic anticoagulant therapy, especially for those patients, and intraoperatively pneumatic compression device.
So directly after the operation, you are performing the DVT prophylaxis for all patients.
Intra, post, perioperatively.
Is it for all patients?
Weighing the risk of bleeding.
So is it for all patients? Are you performing for all patients?
Yes, VT prophylaxis assessment should be done for all patients undergoing surgery.
Yeah, this is what I want to say. The assessment. So you're performing assessment, then you can decide you perform heparin or no. Am I right? So the second risk area is the abdominal pelvic lacerations. Did you encounter any kind of risk, this kind of complication during your hospital experience? Can you share your experience? Did you encounter such an incident?
It's actually mostly with the laparoscopic, I think so.
Due to equipments utilized.
Yeah, because I think this is mostly high with the laparoscopic procedure, if I'm not mistaken.
So usually, usually it's an accidental punctures, and the treatment or the solution is should be identifying there was an incident, and then do the right action to avoid the complications, and also to use simple techniques that would have a minor risks. So post-operative wound.
Post-operative
wounds.
The
surgical infection.
Yeah, the infections. Yeah. So
hernia. Sometimes wound gapping.
And due to what you usually, Annie?
Infection, most probably infections, wound gapping, or it's
so
stitched properly.
So what is the current procedure that our hospital are utilizing to prevent the infections or post-infections?
Antibiotics, prophylactics before or during the surgery.
That's right, yes. So, the third one, iatrogenic pneumothorax, which is usually due to wrong placement of central venous catheter or feeding tube. Usually, currently, they are doing like an ultrasound real time while when they are placing the central venous catheter or the feeding tube to avoid the pneumothorax. The post-operative acute kidney injury due to the patient, he is elderly, patient having risk factor of having kidney injury, diabetes, and usually the solution to have adequate hydration, adequate fluid for the patient. If he's taking medication can cause renal failure, you need to do dose adjustment and even avoid the nephrotoxic medications. The post-operative respiratory failure, which is linked also to because of the narcotic medications or the opioid medications, having pneumonia, aspirations. So usually the solution first, you need to do a pre-assessment and optimize the medications and monitor the patients. The post-operative cardiac complications usually is due to unmanaged or non-risk factor. If the patient having heart failure and he was not taking his medication and there was no pre-assessment for the patient, this can cause post-operative cardiac complications. So the solution is to have an assessment before the surgery and have the adequate treatment. The perioperative hemorrhage or hematoma due to a failure, if there is any risk factor of the patient having hemorrhage or there is a risk having bleeding, so the solution you have to monitor the vital signs and to monitor the urine output, the peripheral perfusion, and also give blood transfusion for the patient and pre-assessment. The third area will be the infection. There's two types of infection, the hospital-acquired infections or site-specific infection. The hospital-acquired infection, the precautions or the strategy is to have universal precautions and, as you know, the hand hygiene for the hospital-acquired infection. For the site-specific infection, like post-operative surgical wound infection, central venous catheter infection, urinary tract infection, and resistant organism. For the post-operative surgical wound infection, what is the strategies, as we mentioned before, to prevent the wound infections?
Prophylactic antibiotic and scrub chlorhexidine.
Chlorhexidine, yes, the antibiotics and the chlorhexidine, and it's assessment, the continuous assessment of the wound. How about the central venous catheter infections?
The use of the bundle.
The bundles, yeah. What is inside the bundle?
For the central venous, the position of the patient, the cleaning of the site, the site insertion,
removal of line. First is the appropriate selection of the CV line.
Yes, that's right.
Internal, yeah, and then cleaning of the line site and kind of vacation. So we need to remove consideration of the CV line removal and going back to the peripheral line.
That's right. What about the urinary tract infection?
It's mostly related to the catheter associated urinary. So same copy bundle.
Removing the catheter
at the other
What else?
Appropriate aseptic technique while catheterization.
Mm-hmm.
And other things kind of lower lying urinary bag,
Mm-hmm.
then all the perineal cleaning, all those things.
تمام. How about
Sampling.
how about the resistant organisms? Can you give me an example of, first of all, how one of the يعني give me an example of the resistant organisms, like what?
MRSL,
MR,
MRSA.
DRO.
yes,
Mm.
Still.
So how can we prevent infection caused by the resistant organisms?
Giving the right antibiotic according to the culture.
That's right, excellent.
and avoid too many antibiotics.
That's right.
Avoid changing. There's no.
Yes, that's right. And adopting the antimicrobial stewardship programs, that's right, correct. Ventilator-associated events. So to avoid the ventilator-associated events, the timing of intubation, the oral hygiene by chlorhexidine, elevating the head, reducing the opening of the ventilator circuit, and avoid prolonged sedation and removal of subclinic secretion. Patient falls, fall assessment tool, and patient-specific measures as education and modification of patient environments. However, to prevent the pressure ulcers, usually we are performing the risk assessment tool by Norton, by Braden, Norton, Gosnell, and Waterloo. Skin care, cushioning, and frequent repositioning, and fecal and urinary incontinence. My question, just a question, in صحة, which type of tool we are using? Is it Braden, Norton, Gosnell, or Waterloo? I'm not sure.
Braden.
Braden?
Braden.
Braden,
Yes.
which is the American one, صح? Thank you. Waterloo is the UK. Waterloo is the UK tool, and Braden is the American tool. So, patient safety tools. To get the data of the patient safety, we can have the data can be a data acquisition or analytical tool. Examples of the data acquisition is the surveys and error reporting. When there's a culture of reporting, this is one of the ways to collect data for patient safety. Self-reporting system is it will be like enterprise during in the hospital, collecting self-reporting to create best practices in the hospital. Chart review, as we mentioned before, through the trigger tool for ADR events, and direct observation, which is the situational monitoring. The analytical tool, which is retrospective event analysis and prospective event analysis. The retrospective, which is like root cause analysis, Pareto chart, and fish bones. And prospective event analysis, which is FEMIA, which is failure mood event analysis, which is mostly for the processes. What is the harm categories according to the national NCC MERP index used in the HIA trigger tool? What is the harm categories usually? Which is always when we are categorizing the harm, there is used in the HIA trigger tool. What do you think about those categories? Do you remember those categories? Which depends on the severity, and when the harm is severe, there's kind of classifications.
1 to 9.
Sorry? Yes, Avita?
The same we use for the safety intervention.
Yeah, that's right. The one in the safety intelligence. So I know it's here. This is the National Coordinating Council for Medication Errors, reporting and preventing. This is their harm. Category A, which is we can consider is a near miss, when the circumstances or event that have capacity to cause error, or when there is unsafe conditions. So when there is an unsafe condition, this is the category A. Category B, an error occurred, but the error did not reach the patient, which is the near miss. Here, when there is an error, but didn't reach the patient, will be a near miss. This one, the unsafe condition. C, an error occurred that reached the patient but did not cause harm. Then D, an error occurred that reached the patient and required monitoring. So those are the errors, but considered as a light errors. It doesn't cause harm to the patient. The yellow one, it is the error caused but caused harm. The E category, an error occurred but have temporary harm. The F, it is need prolonged hospitalization or initial hospitalization. The G, permanent harm of the patient. The H, the harm cause need intervention to sustain the life. The I can cause the death. So here, unsafe condition, error without harm to the patient, error with the harm, the I, it is the death. Error prevention cycle, there are 5 ways to prevent error. System approach, which is mostly linked with the leadership. When the leadership adopt the safety culture, then the error will be prevented through enhancing the error reporting, no blame culture, adopting or fostering that transparency within the organization. This can reduce or prevent having the errors. Operational intervention, as we mentioned before, information technologies, forcing functions, those are processes can reduce the errors. Teamwork. The teamwork, as you know, due to the lack of communication or miscommunication, those can cause medication errors. So there's kind of tools that prevent the lack of communication and the lack of or miscommunication, which is like utilizing the SPAR tool, which is the situational. Hello, can you hear me?
Yes, yes.
Oh, yeah. I thought I thought. So if we define, someone can define for me the SPAR tool.
Situation, background, assessment, and recommendation.
The SPAR situation, background, assessment, and recommendation.
Recommendation. When do you use the SPAR tool?
During handover.
During handover. So.
Or any change in patient condition you want to relate to a physician or another clinical team, you can.
Okay. Thank you. The decision support system. What do we mean by decision support system?
RRT. And we have some set protocols,
Mm-hmm.
insulin protocol, something.
What else? Can you have an example?
Rapid we can consider it a decision support system.
Sorry, Hania?
Rapid response team.
What is the rapid response team?
Like in a case of any patient will have a deterioration, then caregiver, he can alert the system, and a set of people who they are trained to evaluate, to decide for the next step of patient. They will arrive on a certain time. So everything will be monitored, then you are avoiding deterioration and maybe unnecessary admission to the ICUs for a patient.
Thank you, Hani. How about the care transition? What can we do during the care transition to prevent error?
Plan of care.
Plan care, that's right.
And
management role, it's like the care plan.
Care plan. Also, I think this part also can utilize, huh?
It's part of handoff.
Yeah.
Yes. We can handoff.
Okay. Tamam. So, the high reliability organization. Can you give me an example of one of the high reliability organization? Okay.
To reach this level?
Like
Aviation.
Aviation. So when we, inshallah, we can reach this level, high reliability organization. So the characteristic of high reliability organization is the preoccupation with failure. What do you mean by the preoccupation with failure?
We always think what can go wrong.
Yes.
Yeah.
So you are vigilant of, you are not waiting for the error.
That's
You
right.
will
That's right.
Intimidate you will put your plans to prevent the error.
That's right.
Like anticipating the error before happening.
That's right. How about reluctance to simplify? What do you mean by reluctance to simplify?
Maybe they look to take shortcuts or quick ways of doing things.
Quick ways to do, yeah. How about sorry?
It's something they are using actually especially in the aviation. When they are investigating something, they will go deeply with it. They will ignore any kind of just to make it simple or it's easy or yes, you can ignore this.
Okay, so is it okay to simplify everything?
Focus on high priority things.
Exactly. I was gonna say, like, for example, sometimes when we do the surgical safety checklist or we do the timeout, we could sorry. Sometimes you might think, oh, it's too much hassle, and why are we doing this all the time with all the patients? We know we have the good systems. So for those that are complex or that are critical to the safety of the patients, then you wouldn't go on and simplify it. You really need it to be done in a robust way.
Yeah. So you don't want to be oversimplified. Okay. How about the sensitivity to operations?
Creating safeguards, especially wherever high risk processes. So there will be some safeguards will be created so that we will be ready to meet those.
Yes. It's kind of, yeah, you develop your barriers to avoid the errors. That's right. Like developing to avoid any kinds of Swiss models, cheese models. Am I right?
And you are not listening to the people on ground. Usually, if you are not listening to the people who are performing the work, you won't get that much understanding of how you can really fix the operations.
But I think this one will link to the second one, the following one, which is difference to expertise. So what you are mentioning now, it is the difference to expertise, mean you are deferring the task to the most suitable people and to the one who perform. Am I right, Hania? So you are saying you need to talk to the one in the ground, صح? So you are deferring the task for the people who have the expert to do the things. Am I right?
It's very similar. They are overlapping.
Mm-hmm.
However, when you are with your operations, means you are understanding the people who they are working from the higher to the lower, then opposite. It's not like the expertise. It's just like you are understanding what is going on. So, and it is on both ways. There is a communication for all the levels. So if something going wrong, those people on the ground, they will help you to fix the operation before maybe it go wrong further. But sometimes, especially in healthcare, they have that ego. Especially the leaders, it's statistically that they have that ego. They won't just go to the frontliners, hear from them directly. Sometimes, so the system, it's not taking that operation in a whole way. Like this is what I remember about the difference between the expertise and the operation.
How about the resilience? How come the resilience, it is linked of one of the characteristics of the high reliability organization?
Actually, the word resilience it's
to be prepared for any unexpected threats.
Yes, that's right. It's like adaptation for the changes. So you're easy to adapt, do the changes in your system to combat any kind of failure. Yani.
So even though they thought about the risk, they have their processes, they are sensitive to their operations, they listen to their expertise and front lines. But resilience is when the threat is happening, they also have mitigation plan addressing it and
what I was mitigation plan.
Yeah.
Yes.
So the bundle interventions and the patient safe collaborative. What is the difference between the bundles and the collaborative?
Bundle means like you have a set. It's created and usually it's evidence based. So people they can just do it. Just go ahead and do it.
Set of what? Set of what, Hania?
Of rules or communications or procedures. Like what we are using for the IHIs for the let's say the infections in the hospital to prevent the infections. So we have a bundle of care of pneumonia. We have a bundle of care of maybe and other things like.
Yes, it's a set of care or processes. That's right. How about the collaborative?
Collaborative,
multidisciplinary plan of care.
Yes, it's an initiative contains all the bundles together. So it doesn't relate only on one task. For example, it is multiple stakeholder. They are sharing one aim with multiple initiatives, and for example multiple bundles, for example. So the collaborative, it's the bigger, which have a multiple initiatives, and the model, it's just a set of care or set of processes you are dealing for certain category. For example, VAB bundles, for example. So I think this is the last slide. So just to refresh you, just questions.
Sorry.
Go ahead.
By the way, for the bundles are very specific. Sorry, Hania, you were saying something?
No, I was just want to ask about the collaborative. It's only for the bundles, we will say, within patient safety, or maybe we can even say like the M&M, it's a collaborative.
That's true.
Patient safety.
Collaborative is anything where you have a group of the multidisciplinary team that are participating together to come up with solutions or recommendations for better performance. So here they give example, for example, about the CUPS, the unit-based safety programs that were created, and the CUSP were actually one of the ways that have initiated or even encouraged the use of bundles and other things in the care of patients. The bundles are maybe disease-specific, equipment-specific, condition-specific. It has a set of interventions that, if complied with, will help definitely reduce the risk of the safety incidents happening. The Patient Safety Collaborative, from the name collaborative, it's a group of people that came together to improve multiple processes. It's not only those that relate to bundles, but it could be anything within the unit, or if Hania just said the M&M team, there might be other teams that are developed in the unit.
DTS, no? Sarah,
DTS for now is the same thing. It's a multidisciplinary group that works. DTS is the daily team system, and their aim is they have a common goal and aim, as Rabab said, and they are working together to achieve that goal. And here specifically is talking about patient safety goals as a goal. Thank you.
Thank you, Zahra. So I think this is the last slide. Just quick questions for what we talked today. A failure described as an autopilot mode. Which one is the following? Knowledge base, skill base, rule base, or none of the above?
Skill.
Active failure is considered one of the following: person approach, system approach, planned and latent failure.
Active.
Sorry?
So,
person approach.
Person approach. Correct. One of the following is not an assessment tool for risk bed ulcer. Braden tool, Norton tool, Waterloo tool, or Nelson tool.
Nelson?
Nelson tool. The following are the strategies to prevent VAB, except avoid prolonged sedation, oral hygiene, cushioning, and head elevation. Cushioning. One of the following below strategy is not for prevention errors caused by fatigue. Coffee consumption strategically. Maximum allowed working hours is for 84 hours. Simplify the process. Have a nap periods.
Maximum allowed working hours. Not to give 84 hours.
It should be, how much it should be, Savita?
40.
40 hours. يعني so in صحة we are beyond 48 hours.
Because you know they will say we give 1 hour break.
The father of infection control, Schimmel, Goodman, Similowitz, James Reason.
Goodman, صح؟
Goodman.
No, it's one of the S. I don't remember whether it's Schimmel or Similowitz.
No idea.
Okay. Similowitz.
Lewis, okay.
Schimmel, Goodman, the end result theory, James Reason, the owner of the book of the human errors, and the Swiss Goodman, Schimmel, the one who said he reported that medication errors can cause almost 14% and 6.3 ADRs, 20% ADRs was in the hospitals and 6.6% was fatal. So similarly, he's the founder of the infection control and hand washing technique. One of the below statement is correct. Nursing home prescribing errors are twice more than the inpatient hospital setting. Administration errors incident is 15 to 1400 errors per 1000 hospital admission. Ambulatory errors mostly caused by low literacy and patient education. Preventable adverse events are unexpected or dangerous reaction to medication process. Which one is correct?
First one.
Number 3.
أي واحد.
Ambulatory, the third one.
Ambulatory.
Ambulatory. Correct.
The first one, Hania, the inpatient hospital is more than the nursing homes, not the other way around.
No, the nursing home is more than the inpatient.
لا لحظة. The nursing home administration errors, not prescribing errors. So أنا غيرت هنا. I changed.
Time to twist us.
Yeah, she played with our minds.
The nursing home administration errors are twice more than the inpatient. However, here the prescribing errors incident is the 15 and 400. This is not administration, should be a prescribing errors. For the preventable adverse events, we said that the adverse events caused by the medication errors. But however, this explanation, it is the medication errors, not the adverse event. The highest number of medication errors incidents caused at the phase, the highest number of medication errors incidents caused at the phase, prescribing and dispensing, dispensing and administration, transcribing, dispensing and monitoring, prescribing and administration.
Prescribing
and administration.
The last one, prescribing.
Yeah. Thank you. Thank you very much.
Thank you, Rama.
Thank you for your support.
Very nice, excellent. You tried to twist us. Great work.
لكن I'm nothing like Zahra, to be honest with you. لا. Zahra, you'll continue, no way.
To be very honest, I enjoyed the session.
We enjoyed, Rama.
You did well. You did amazing. amazingly well.
اوه ثانك يو. لا 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 كلمة amazingly دي صعبة شوية. خليها اوكي you done well without amazingly.
No, you did very well. Amazingly well, والله. إن شاء الله. Even the slide, I looked at the slide, it was very, very well done. It shows that you've spent time really looking at resources, putting pictures, so it's not done like it's in the book, looking for additional examples, so it was all good. Thank you very much.
Thank you Zahra.
Can you stop the recording, Rabab?
وهنا
No, continue sharing your screen, please.
okay.
Thank you, all you can go. We just want to make sure that the recording is synced.
Okay, thank you.
I will share the screen now.
Thank you.
Okay.
Thank you.
Thank you. See you next week.
Yep. See you
Okay.
Okay. So زهرة نقفلها من وين؟ هلا نسيت
إذا أنت فوق تحركين الماوس بيطلع لك المفروض فوق ال
كلمة ريكورد.
لا
لا
لا لا لا مش هنا.
ايوه هي
أي واحد.
بوز.